Hello, my name's Bill McGuiness, for those who don't know, and I've been involved in wound management for over 25 years, both as a clinical nurse consultant and as an academic. Today, I really want to talk about slow to heal wounds, but more importantly, how do we go about preventing some of the often disastrous outcomes of having a wound follow that particular trajectory? Just a quick declaration of interest. What I present is of my own research, both from the literature and from my own studies. And don't represent the opinions of companies at all. Now, we know from principally animal-based studies that the wound healing itself in acute wounds follows a given trajectory. And we know that given trajectory is a series of overlapping physiological processes that are mitigated by a number of cellular activities, beginning with mast cells and finishing with epithelial cells that are really controlled by a group of proteins, of course, called cytokines. None of that is new to you, and you are all very adept, I suspect, at being able to recognise the different stages of that healing process by looking at the clinical manifestations of your patients. You can see down there below with the inflammatory, destructive, reconstructive, and epithelial cover phases. Here's a classic example. 23-year-old female police officer suffered from meningococcal disease. She's a non-smoker and not taking any medications at the time. So a lot going for this particular patient in terms of her healing of this wound, this septic wound on her elbow. And we can see that with a little bit of debridement a week later and cleaning it up, and after about 29 days, we've actually now got almost complete healed wound. Being over the elbow, which is being flexed fairly constantly, it will be a little bit slower than the average acute wound. But we can see progress, and we can see we're going to probably finish this. There are, however, times, though, when this process is elongated. It's actually stretched out over a period of time, and in some instances, the actual process even stops and no further healing is identified. Now, people tend to call them either chronic wounds or more commonly now slow to heal wounds because they've fallen off the healing trajectory and no longer progressing as we would like. Again, here's an example. 25-year-old female, steel fabricator, developed lower leg ulcers, non-smoker and non-medication. So again, similar sort of case to the first case. So this should be, give or take the etiology, again, a healable wound. But we can see over time, a month later, we're starting to get there, starting to win. And 2 months later, almost completed. But then 3 months later, we're confronted with, again, quite a large ulceration. And 4 months later, we're starting to go back into the contracting phase again. And you can see 6 months later, we're actually starting to heal the wound again. Now, this gives us this sort of picture of, say, the acute wound you can see running along the top there, okay? And then this chronic or slow to heal wound following these periods of breakdown and heal, breakdown and heal, breakdown and heal. And I want to put it to you that that's that process of which I call the yo-yo of wound healing, that is the most destructive form of healing that we are involved in as wound healthcare practitioners. Now, if we want to define it, it's probably pretty good to go to the actual yo-yo dieting literature, where they talk about a cycle of constantly gaining and losing weight. Now, in this instance, there's difficulties in maintaining body weight reduction. A pattern of weight cycling often occurs, okay, and may result in deteriorous outcomes to health. And it's the same, I would argue, for yo-yo wound healing. Okay, if we want to try to put some sort of definition around it, is this notion of a repeated breakdown and repair of wounded skin, resulting in negative psychological and physiological and psychological outcomes for the patient and the healthcare professional. And I put both of them in that tag because I'll hope to demonstrate to you soon that it affects both cohorts, both the patient and the healthcare practitioner. So what are some of these aspects that foster yo-yo wound healing? Well, a lot of literature has been presented to it, and we often think about it in these sorts of categories. Firstly, there are a number of wound factors, the etiology of the wound. Venous hypertension versus an acute wound we know has certain complications in terms of the healing trajectory. The duration of the patient's had the wound is again the impact on how quickly it can be healed up. How clean the wound bed, we know now from research, a lot of these slow to heal wounds contain a film of bacteria, principally biofilms as it's called, or a heavy burden of bacteria. And then we know that sometimes the peri-wound may not be as healthy as we would like because of irritation from things like feces and urine, or just irritation from dressings and that, or tapes that consistently damage it. The patient factors we also start to talk about. Has the patient got some other health issues or chronic issues? What is their current health status like? So they may well be a diabetic, but if that's well managed, they've got a fairly good health status. And the opposite is true. Their mental health and coping capacities we often look at and say, well, are they coping reasonably well? Do they have a positive outlook around some of the wounding? And then we start to expand our gaze to context, where we start talking about social supports, fiscal reserves a patient may have access to, and the access that the patient has to relevant healthcare, be it a clinician or be it specialised services or investigations. Now that's fine, and every wound assessment incorporates all of that approach to see what is the propensity of our patients to heal. But we often tend to talk about these in separated or segregated areas of importance. And I would argue that probably often we tend to give more weight to the wound factors as we try to heal patients, only because we have products that have been designed to change physiological processes, and we have some knowledge around what that process should look like. However, this paper published in 2019, late 2019, by Fayer, actually starts to challenge that notion of trying to separate out some of these processes and address each of them individually. Fayer argues that really what we do socially, psychologically, has an impact on our genetic activity, the way in which the genes express themselves. And I'm going to run through some of the examples that she cited from examples from other literature that really start to highlight the interrelatedness of these particular phenomena. The first is social isolation. And I picked this one first because it's often the thing that we think about last when we're managing patients. Social isolation has been shown to actually have impact greater than 200 of our genes, with a greater than 50% variation of the impact on those genes between people who experience chronic social isolation versus those that are socially integrated. The impact on the genes you can see listed there. So if there's a down-regulation of genetic function, it tends to affect the genes that are responsible for antiviral responses and for antibody production. Upregulation of genes tends to be those that are involved in the inflammatory cascade. So just by being isolated, we tend to be decreasing our response to bacterial invasion and increasing our inflammatory response to the actual wounding itself. So to separate social isolation away from physiological responses may well be a false separation that's stopping us getting to what we need to help with these particular client group. Another aspect is the visit to the wound clinic. We have people, or we go to their homes in some instances, but we spend an interaction with them to tend to their wounds, if you like. And there's research here that shows that a frequency of clinical visits does actually influence wound healing. A lower frequency equals a lower healing probability. Now, people argue that this might be linked to the fact that people have a shared sense of belonging by coming to groups or coming to clinics or coming to just the interaction with yourself in their home. And it's that sense of belonging that then starts to address some of that social isolation we just talked about. But again, there's quite a demonstrated research that says the time that they take to see you, or the ability they have to see you, actually impacts on whether they're going to heal or not. Psychological stress is another major component of wound healing that would be argued from the genetic expression argument. We know that when you're under psychological stress, you increase your production of glucocorticosteroids and catecholamines, which we know then delay wound healing. This study you can see here, this, number 2, by Goog, showed that women with perceived stress had lower levels of interleukin-1 alpha and 8 at the wound bed within 24 hours of them being wounded or an onset of wound. There was also a study that showed lower levels of interleukin-1 beta and 6 and tumor necrosis factor alpha were found after marital argument than following a social support discussion. So after marital argument, there were lower levels of those 2 important cytokines that stimulate wound healing than for people who had just had a discussion around social support. Another study looked at punch biopsies taken, and they found a significantly longer time for a punch biopsy to heal. And we all know punch biopsies tend to heal even in patients with chronic wounds or slow to heal wounds. But they found that punch biopsies took significantly longer to heal in people who were caregivers of dementia patients. And an animal-based study, a mice-based study, you can see listed there, number 4, quite clearly showed that when you restrained mice, they had a 5 log increase in Staphylococcal aureus in their wounds. So just by looking at relieving the stress of our patients, anxiety-reducing activities such as support may well start to address some of the healing problems we're being confronted with and stop that yo-yoing. Socioeconomic status is another area that needs more attention than I think we give it. Now, it tends to be defined around things like marital status, probably an outdated mode in this current climate, employment, income, welfare benefits, and housing. So that ability to really have a significant other, have income, and have housing is what social economic status is about. Patients with venous leg ulcers that were single, lower socioeconomic class, and lacked heating in a major study in London done by Franks quite clearly showed there was a significantly prolonged wound healing time. And there are a number of other studies that show that the lower the socioeconomic status, the longer time it takes to heal a wound, probably because of access to facilities and products. The other area is education status, and we know patient education is important. The literature and the books are full of it. But do we ever really sit down and say, well, how are we giving education and how is it impacting on the wound healing of the patient? So here's a study that quite clearly shows that your level of education has been associated with 74 loci regarding gene expression in neural tissue. The second study you can see listed there found higher rate of 77% of wound healing in a population with higher levels of education. So the better educated you are, the higher or the faster you heal. And patients have been found patient education has been found to significantly contribute to wound healing. Patient education intervention study you can see listed there demonstrated a decreased recurrence rate from 69% down to 45 to 50%. So just by making sure the patient's aware of what's going on, you're actually starting to not only improve healing, but decrease recurrence rate, that yo-yoing that I've been talking about. So there's some of the contributors, I think, that you'll see that really probably need our attention rather than the wound and the wound bed. It's more about what can we do around the patient that will then improve the body's ability to heal that wound. Now, there's a number of outcomes that are associated with this yo-yo of healing. Okay, the first is there are a group of physiological responses which tend to fall into the repair rather than the regeneration side of the equation or the continuum. So what we see is no basement membrane or disorganized extracellular matrix. Epithelial cells don't migrate from area of proliferation. We get substitute epithelial cells with principally connective tissue, which we know is, well, was often called a scar formation or scar tissue, which we know can easily be re-wounded and isn't as flexible and ability to regenerate as normal skin. So from a physiological point of view, allowing our patients to have a yo-yo healing cycle means we're increasing our propensity to have more scar tissue. Have a look at the lower leg of people who have had recurrent chronic venous leg ulcers, and you'll see large amounts of scar tissue between their knee and their ankle. The other impact of allowing yo-yo healing to occur, or yo-yo of healing is that there are psychological impacts on the patient. And here's a study that was conducted back in 23 where they actually started to review all of the literature and what was cited by patients and by clinicians of actually having a chronic or slow to heal wound. They quite clearly showed things like this: reduced quality of life, anxiety, depression, suicidal ideation, blame, feelings of guilt, hopelessness, fatigue. A number of our patients are chronically tired when they're having a wound that's just not progressing. Irritability, social isolation, some form of stigma around smell or leaking, sleep disturbance because they're waking up with wet bedclothes and that sort of thing from exudate. But wait, there's more. Embarrassment, irritability, negative body image, concentration problems, and anhedonia, I should say. For those who don't know, and I had to look it up, it's the inability to find positive things in positive situations. Inability to work, reduced independence, financial difficulties, clothing and footwear restrictions, feelings of disgust, feelings of low self-esteem, and striving to remain positive for loved ones. So they're trying to put a brave face on all of this while at the same time feeling guilty and feeling hopeless. So the psychosocial impacts of allowing a person to heal, break down, are far-reaching, and they in turn contribute to the chronicity of the wound that we're managing. But it's not just the patient's physiological and psychosocial impacts. It actually impacts on us as health professionals trying to manage patients with yo-yo forms of healing. Here's a study, here's the study you can see listed there, where they actually start to look at the literature around impacts of health professionals, of things that take a long time to heal. Now, unfortunately, we don't find much in the literature about the impact on health professionals of long-term healing or delayed healing in wound care. It's work that needs to be done, but certainly there's been work done in other areas. And I think most telling is some of these type of findings. Firstly, it challenges our expertise when we can't heal these wounds. We get them progressing nicely and then they break down again. That ongoing failure actually starts to contribute to our own anxiety, our own depression, in some instances burnout, in some instances resignation or loss to the profession. So we shouldn't underestimate yo-yo healing because it does have an impact. And it can interfere with our patient-client relationship and lead to labelling. You can see right back in 1958 when a study canvassed clinical physicians, nurses, social workers and clerical workers about the difficult patient. The consensus of that discussion was really the difficult patient is one who makes me feel ineffective. And you can see the second study down there found that patients who failed to validate clinicians' sense of themselves, in other words, I know what I'm doing a good job, look, I've just healed your wound up, tend to threaten control and created fruitless work and was subject to being labelled as bad patients or problem patients. So not only does it start to impact on our own feeling of self and our own abilities with some possible psychological outcomes, it actually starts to interfere with our relationship with the patient, which we said earlier is one of the most important things about trying to facilitate wound healing. So enabling something to yo-yo starts to impact on ourselves as well as the patient. So how do we stop this whole yo-yo cycle? What are the important things to do? Well, there are a number of things, and obviously addressing things like etiology and getting wound care right and all that is really important. But what I would ask you to do is to broaden your horizons and start to think about other areas that you may well have relegated to less important when you manage the clients. The first, I would argue, is you have to recognise that it's a collaboration, and it's a collaboration that needs probably a fairly large team. There is going to be a need for agreement about who's doing what when, right up front, and then continually reviewed. Because when we're clear about who's responsible for what, the patient education stuff then becomes quite obvious. The patient understands what's happening. When they go to the dentist, they sort of understand what's expected of them. When they go for a haircut, they sort of understand what's expected of them. Sit quietly and have lots of the gossip. So what we're trying to do is to do the same thing around wound care. Help them identify their expectations and our own. It is going to require some healthcare interventions at some stage, some investigations, some procedures, some reviews. And they need to know what they look like, and they need to know what their part is and what your part is in that particular interventions. There is going to be a requirement for some lifestyle change. Most of the time, we need to lose some weight. We need to give up smoking. We need to look at our diet. We need to have more exercise. All of those things we know, all of us know, are important. But when it gets to this sort of wound healing, we need to change lifestyle. So who's responsible for that? What can we do about changing the lifestyle, and what does the patient or the client do about it? What sort of social supports, mobility, hygiene, housing, and that sort of thing need to be addressed to heal the wound? And it is going to require some fiscal resources. Okay, you can't heal wounds for nothing. And I think we'll try to and give it our best shot, but we can't. So it will require some resourcing from the healthcare system. It will require some resourcing from the patient, some out-of-pocket expenses. And there is very important for us to identify, are there any grants or other benefits that we should be tapping into? So when you actually work out the collaboration about who's doing what, when do they occur, what does that plan look like, you start to get some structure that the patient can live within. And we all know through the COVID clients, that COVID crisis we've been experiencing, that when you take the social structure away, it gets really hard, okay, psychologically and physiologically. And then you need finally some discussions about what happens if we don't meet some of these obligations, okay? What are some of the potential outcomes of me not doing my job or the patient doing their job? Really important discussions to have. You can make light of it, you can make it a joke to help with the patient, understanding if they have a propensity for that. But the important thing is you actually get this collaboration identified and bedded down. To help with that, you need to keep the majority of your decision makings between the client and the team, right? We know that there are times where you just want to spend time with yourself and the team, and there's times when you're going to want to spend time between yourself and the patient. And there are some times where you just want to think things through with yourself and consult with yourself. But overall, we should be aiming for having the most of the decisions in the quadrant that involves the team and the client. And that's going to need us to look at some healthcare system re-engineering. Some of us are lucky to have worked in multidisciplinary teams where we're able to work with the patient on an ongoing basis. The vast majority of healthcare, though, is delivered around the needs of the clinician, and they're often separated specialties that patients are dragged through, be they for investigations or be they for treatment. So as we start to look at the patients that are yo-yoing, we do need to think about how do we set a team around them that meet regularly, that gets ideas onto the table that may well stop what we're seeing in terms of the healing cycle. So we need a collaboration. We also need a clean wound. Okay, and I think all too often we, up until recently, have looked for products and other more technological interventions, if you like, to help address some of the problems we're seeing in yo-yo healing. But at least the consensus paper that was brought out in 2020 quite clearly identified for us and refocused us on this notion of a clean wound is important, wound hygiene. I don't care if you follow the 4 stages of the wound hygiene as demonstrated in that document, but we do need to be asking ourselves on a consistent basis, do I have a clean wound bed? Because without it, you will have yo-yoing because bacterial colonies come and go. That's part of the yo-yo experience, if you like. There's infection and reinfection. We do need to provide bathing opportunities for patients who haven't got them. And we do need access to laundry facilities for people who are unable to wash their clothes in there. So yes, we know these are difficult issues, but by working with our social supports colleagues, we can start to address them, or just keeping an eye out in our local papers and that. Well, we've now got a number of these services where people will come, set up a few chairs and enable homeless people to come and actually wash their clothes in these portable washing machines in backs of vans that are now through a number of our larger metropolitan areas and some of the regional areas, I have to say. So the abilities are there to keep a clean wound. It's really trying to find them and build them into the management plan. And then the final thing I'm going to say is that's important to being yo-yoing is this need to review regularly. The yo-yo will keep yo-yoing unless you identify the yo-yo pattern early and start to try to get it up and onto a trajectory of healing, such as this, rather than this up and down yo-yoing effect. So set yourself a time to heal. It can be based on the etiology, or should be. It should take in the severity of the etiology. So the etiology of venous leg ulcer, the severity might be it's a simple venous leg ulcer. And then factors that assist or hinder the healing in that particular client. So taking all that into account, you should say, I expect this to heal in 4 weeks, 10 weeks, 12 weeks, 3 days, whatever you determine based on your experience and based on the evidence. But what you're trying to do is to say, look, I'm setting a hard stop. I'm not happy with going up and down the healing cycle. I'm going to have a hard stop where this has got to be intact and completed. Determine the review points as well. Okay, when do you want to do the reviews, and establish criteria for each review? Is it going to be surface area reduction? Is it going to be amount of necrotic tissue? Is it going to be a reduction in exudate to things like minimal exudate, for example? Is it going to be a reduction in smell? Is it going to be a reduction in patient's pain? Is their quality of life going to improve? You need to have the criteria, and it will be a mixture of all of those, we know that, but you need a primary one. So the patient knows the goal and they know the endpoint. So you've got that time to endpoint and you've got the goal, then they start to have, again, more surety. And you do too, which is better for your own psychological support, because you actually got a plan you're working to, rather than scratching your head and thinking, what have I missed here with this patient? If you do regular reviews, to start to look for tools that help remove some of the subjectivity. It'll always be subjective clinical appointment, and that's what clinical assessment, and that's what makes people experts, if you like. But if you can get some validated tools, it means that when you've got multiple people making assessments, you then start to get a bit of clarity around the actual picture and then document the healing journey. I don't care how, but think about how you actually get some representation of the journey to see if that yo-yo is occurring. Here's an example of a validated tool. Okay, this is the grey exudate continuum, and she has criteria for each of those. But by simply looking at viscosity and volume, you can come up with a score out of 10 for exudate. And you then might say, look, I'm sitting on 8. I want this to be a 5, a grey exudate continuum of 5 within 2 weeks. Otherwise, I'm not controlling the exudate. I'm not reducing the bacterial burden. I'm not reducing the inflammatory cascade that I'd like to be doing. So I'm just saying there are a number of them out there. I'm not going to go through them in half an hour, but there's a number of different tools out there that will help you identify the different, objectify some of the assessments you make. And then document the healing journey, as I said, okay? So things like photography, sequential photography, or regular measurement, or plano, I don't care what it is, but what you've got is some evidence that you're on a trajectory that is a steady trajectory. So here we have a wound that's quite clearly moving to a healed state. It's these photographs that often help you identify when you're starting to yo-yo, plus your documentation that, of course. But when you start to see that yo-yoing, like that case I showed you in the early stage of this presentation, that you can stop, reassess, start replaying again, because you're on a path you don't want to be on because of the outcomes that I've highlighted. So in summary, we know that wounds heal using a number of overlocking physiological processes that are constrained by time and social genomics. Failure to balance each results in delayed healing. Okay, and it is a balance. Managing wounds is about balance. Delayed healing may yo-yo between healing and breaking down if not managed properly. So whilst we can have patients that have a delay healing, they're not yo-yoing. They're just on a longer trajectory than we would expect because of mitigating circumstances. It's that group that come up and then go down. That healing, that breakdown, that healing, that breakdown, that we will get if we don't properly manage the delayed healing. And we can minimise yo-yoing via a productive partnership with the patient so they and you both know what you're working towards. A clean wound and clothes and that go around it, and regular review with documentation that enables you to assess where you're up to. That includes a time to heal, and it includes criteria for assessment during that healing process. So I hope what I've said to you, or the message you're taking home from this is look wider, think about putting into place things that are needed to stop the yo-yo. All too often we say it's too hard. I can't change the patient's social setting. I can't give the patient more money. I can't keep him cleaner. Well, we can. That is part of our role if we're going to stop yo-yo and be serious about ending chronic wounding and the suffering and the costs that are associated with this epidemic, really, in our elderly clients and some of our younger ones. So thank you very much for coming into the seminar. I hope it's been of some value. If you need to talk to me at any stage for other comments or questions, please feel free to do so through the Wounds Australia website. Thank you very much.